and welcome to our June CCTST Grand Rounds. This is Catherine Bowers from the Division of Biostats and Epidemiology at Cincinnati Children's. Just for a couple logistics, we're going to wait for questions till the end, so feel free to just put questions in the chat, and we will get to them at the end. And we may be able to just let people off mute to engage in discussion. We have a really exciting talk today, but I'm actually going to turn the microphone over to Moises Human, who's going to introduce our speaker today.
Thank you, Catherine. So it's a pleasure and honor to introduce Dr. Chris Longenecker. Dr. Longenecker is a non-invasive cardiologist and professor in the Division of Cardiology and the Department of Global Health at the University of Washington School of Medicine in Seattle. He is the inaugural director of the University of Washington Global Cardiovascular Health Program, where he oversees an extensive NIH and foundation-funded program of research focused on mechanisms and prevention of cardiovascular disease in people living with HIV, implementation science to improve rural cardiovascular care in the United States, and rheumatic heart disease. Clinically, he attends on the Harborview Medical Center Cardiology Consultation Service and is director of a unique HIV cardiology clinic within the Madison Clinic at Harborview. Dr. Longenecker has been a wonderful collaborator to our clinical and translational science programs at University of Cincinnati and Cincinnati Children's. He's very familiar with the area. He grew up in Bellefontaine, Ohio, and went to medical school at The Ohio State University. He then completed his internal medicine residency at University of California, San Francisco, and cardiology fellowship at Case Western University in Cleveland. He was faculty at Case Western for several years before moving to the University of Washington. So Chris, thanks so much for being with us today, and you can take it from here.
Well, thanks so much, Moises. Yes, I am a Buckeye and really honored to be here today to talk to your group about something I care very passionately about, which is global health, but also how do we take lessons learned from our global health work and improve care delivery in the United States. So we'll get to that. Please do feel free to put questions in the chat. We will get to them at the end, and we'll allow people to unmute and engage as well. So this is the outline of my talk. I'd like to start with an overview of our Global Cardiovascular Health Program here at the University of Washington. We'll talk a little bit about what the definition of reciprocal innovation is, and talk about how it applies to implementation research. We'll then kind of focus on my main area of research, which is improving cardiovascular health for people living with HIV, and two projects, one called Extra CVD, the other called Palesa Uganda, which are implementation research projects that have an element of reciprocal innovation. And then we'll talk about our AHA-funded Rural Health Equity Research Network in the final segment of our talk. How can lessons learned from global health improve cardiovascular care in rural America? So first, the Global Cardiovascular Health Program. If you want to snap the QR code here, it'll take you to our website where you can find out what we're up to here in Seattle. We really work all over the globe with some focus primarily in Africa, with key partnerships in Kenya, Uganda, and Mozambique. But we also work in Latin America with Moises and others in Peru, and with a group in Brazil. And then in Asia, particularly in Nepal and Vietnam. We have some particular areas of focus in terms of methodologies. We really love implementation science, and parts of that, including economic evaluation and costing. We have some expertise in that. And our focus also on qualitative methods to supplement our research. We are partnering with key disciplines to do this work. We're very interdisciplinary. The key partners really are nursing, endocrinology, and neurology. And so if you have any further questions about the Global Cardiovascular Health Program, please feel free to reach out to me, and we can think about how we might partner. So what is reciprocal innovation? Well, the group at Indiana University has defined it as the bidirectional, co-constituted, and iterative exchange of ideas, resources, and innovations to address shared health challenges across diverse global settings. And this was originally conceived by their group as global to local and local to global reciprocal innovation or global health reciprocal innovation. But we have taken that further to think about other axes of reciprocal innovation, such as rural to urban and academia to practice. The idea at the end of the day is connecting innovators in one context with adopters in another context. And if you can get the two to work together, you might be able to overcome problems in a more rapid fashion and have innovation diffuse more rapidly. And this is fundamental to the idea of reciprocal innovation. It's the idea that there are shared challenges to achieving equitable health around the world. Barriers like insufficient health workforce, transportation barriers, adverse social determinants of health, low digital health literacy, or fractured trust in the medical system. And if someone, someplace around the world has figured out how to overcome some of those barriers, maybe that strategy might be adaptable to another context around the world. You know, this term kind of has its origins in a term called reverse innovation that was coined by Jeffrey Immelt, the CEO of GE, with regard to an ECG technology that was developed in India, but then adapted for the Western market and really found that it took off as a low-cost alternative in the Western market. And so it kind of went from a low-income country or middle-income country to a high-income country. And they called this reverse innovation. But reverse innovation implies that there's a normal direction that innovation should flow, that innovation should be flowing from high-income countries to low and middle-income countries. But we challenge that concept with the idea of reciprocal innovation, that really innovation should be flowing in both directions and can flow in both directions. So now let's move on to talk about reciprocal innovations to improve cardiovascular health for people living with HIV. For those of you who are less familiar with HIV, the UNAIDS estimates that there's about 40 million people living with HIV around the world. And we've obviously achieved dramatic improvements in outcomes for people living with HIV. In particular, HIV mortality has declined dramatically over the last 3 decades, as shown here in data from the Global Burden of Disease study that has resulted in an increase in prevalence because people are living longer, and that's a good thing. But at the same time, we see that non-AIDS comorbidities are on the rise, things like cardiovascular disease and renal disease and cancers. And that is in part because people living with HIV have a higher risk of these comorbidities compared to people without HIV. And the relative risk of HIV versus HIV negative is shown here in the y-axis for 3 cardiovascular conditions: myocardial infarction, stroke, and heart failure. And you can see that while this is certainly true for men, it's even magnified for women. And so when we think of non-AIDS comorbidities and cardiovascular disease in particular, we obviously need to think about women as well, even though in this country, the HIV prevalence or the HIV epidemic is largely in males. When we think about the global burden of cardiovascular disease due to HIV, we have to think about not only that relative risk of HIV that's contributing to cardiovascular risk, but also what is the prevalence of HIV as that risk factor in the population. So both the relative risk and the prevalence in the population contribute to population attributable risk. And in our publication in Circulation in 2018, we showed that the population attributable fraction is really highest in sub-Saharan Africa, primarily driven by that higher prevalence of HIV in Africa. But if we think about the totality of risk factors for cardiovascular disease in people with HIV, it's not actually the HIV-specific factors that are driving risk overall. And in this study from the North American AIDS Cohort Collaboration, we see that the population attributable fractions for myocardial infarction, at least in North America, are primarily these traditional risk factors for total cholesterol, hypertension, and smoking. whereas the HIV-specific factors like low CD4 count or elevated viral load are less important on a population level. So we believe that it's now time that we kind of change our paradigm about how we think about HIV care. It's no longer just the HIV care cascade, right? We know that in order to achieve optimal outcomes for people with HIV, we need to obviously diagnose HIV, prescribe antiretroviral therapy, and then have patients take that antiretroviral therapy as prescribed to achieve suppression of the HIV virus in the blood. And while many people are obviously moving upstream to try to think about how do we prevent HIV infection in the first place with PrEP and other interventions, and that's extremely important. We also need to focus on these people who have achieved that final 95 of the HIV treatment cascade, and there are many of those people in our clinics to now extend the HIV treatment cascade for cardiovascular prevention by appropriately diagnosing risk factors like high blood pressure and high cholesterol, appropriately managing those with medication and lifestyle, and then pushing the medications and lifestyle interventions to achieve appropriate blood pressure and cholesterol goals. And it's only by doing that that we can achieve healthy outcomes for our patients. But there are real barriers to this in the United States. And one of those is this misperception of risk. And when I started my HIV clinic, HIV cardiology clinic in Cleveland back in 2013, I had many patients who would come to me and say, I always thought I would die of AIDS. And while that used to be true, it's no longer true. And so they said, I never worried about smoking because I always thought I would die of AIDS. And this misperception of risk was illustrated in the study that correlated actual ASCVD risk score with perceived susceptibility to CVD, led by Alison Webble, case. And you can see there's really very minimal correlation between those two. So this misperception and lack of correlation of risk with perceived susceptibility is real. But what other barriers do we have in HIV clinics? Well, we have this issue where the care is sometimes fragmented, where sometimes people have an HIV doc who serves as their primary care doc as well and provides comprehensive primary care. In other cases, you have an HIV doc who just wants to deal with the HIV and says, okay, you got to go find a primary care doc to deal with your hypertension and hyperlipidemia. Lance Okeke at Duke has been very interested in this phenomenon and how does that affect care. So they did a study at Duke showing that, first of all, a large percentage of people with hypertension and hyperlipidemia are not being prescribed any medications. But among those who are, there's kind of a smattering or a mix of whether infectious disease is prescribing the blood pressure meds or primary care or maybe some other specialist. And they went further to look at whether blood pressure control depended on who was prescribing those medications. And in fact, they showed that if an infectious disease doc was prescribing your blood pressure medicines, you had a 16% lower chance of control. Now, nothing against infectious disease docs. I love infectious disease docs, and many of them do a great job. But in all honesty, not all of them went into infectious disease in order to manage blood pressure and cholesterol, right? They want to treat opportunistic infections. So how do we do this cardiovascular disease prevention within the context of our HIV care ecosystem? So that led us to design this study called Extra CVD, a nurse-led intervention to extend the HIV treatment cascade for cardiovascular disease prevention. And this is part of a consortium of projects around the country funded by the National Heart, Lung, and Blood Institute to improve care for heart, lung, and blood disorders for people living with HIV. And our formula is rather simple. We took an approach of designing a mixed methods needs assessment where we assess the lay of the land in 3 academic HIV clinics in urban settings in Cleveland and at Duke, at University Hospitals and Metro Health in Cleveland and at Duke. And then based on the data from that initial formative assessment, convened a design team of patients, providers, social workers, IT folks, people who had a stake in the intervention, in order to try to think about how do we redesign our processes of care to improve blood pressure and cholesterol care for people living with HIV, and ultimately tested that strategy in a randomized controlled trial, which I'll get to in a second. But first, our mixed methods formative assessment led by Julie Skexnader and others, shown here, basically asks the question, what are the constraints on and opportunities for integrated cardiovascular disease prevention care for people living with HIV? And the design shown there, we had about 51 people with HIV and 34 healthcare providers who participated. And I've talked a little bit about some of the barriers, but just to list additional facilitators of care, we've obviously been privileged in HIV care to be able to access additional resources through the Ryan White Act and Ryan White funding, for example. And that's great. We get social workers and dietitians and others to help us. But we also have lots of researchers who are interested in seeing our patients. And with all of these other resources and people trying to see patients, this leads to bottlenecks in clinic flow. We see other facilitators. One of the things I'd like to point out is that our patients are very attuned to the idea of monitoring their numbers, right? Their CD4 count. They've been doing that for a long time. So can we train them also to care about their blood pressure number and remember that 130 systolic is the key and they need to get under that? And then finally, HIV providers are really trusted sources of medical advice. And so we can really take advantage of that, I think, to improve. Getting at this issue, again, this quote from the study is really illustrative. I just have an HIV doctor, and he asked me the last time I was in if I had a primary care doctor, and I said, "That's you." He said, "No, it's not me." And I said, "I just have HIV. Nothing else seems to be wrong with me, so you're my primary care doctor until such time as I feel I should see one." So again, illustrating that challenge, but also that opportunity with that trust. So again, as I mentioned, we took a human-centered design approach to adapting a strategy to improve hypertension and cholesterol care. This was an iterative process led by Angela Afa at the NYU School of Medicine. You can learn more by reading. Interested involves lots of sticky notes and voting and prioritizing. But I think at the end of the day, we're trying to empathize with end users and say what will work for both patients and providers. And what we came up with is this four-component strategy, which we tested among 300 people living with HIV on antiretroviral therapy, all of whom had both hypertension and hyperlipidemia. They were stratified by the 3 sites and randomized 1-to-1 to receive this strategy versus just meeting with the nurse every 4 months for generic prevention education. And so they were seen at 0, 4, 8, and 12 months when the primary outcome and secondary outcomes were collected, primary outcome being systolic blood pressure and secondary outcome being non-HDL cholesterol. The 4 components are shown here. We thought that nurse-led care coordination would be important for bridging the gap between primary care docs and HIV docs, to use nurse-managed medication protocols and adherence support developed from the Kaiser system. And a really key piece was home blood pressure monitoring. So everyone in that group got a home blood pressure monitor, and the nurse really worked with them to understand what their blood pressures were at home. And then some electronic medical record support tools to kind of facilitate the process and grease the wheels. Enrollment in extra CVD occurred from October of 2019 to January of 2022, and you can see that obviously spans the era of COVID. And so we have not yet been able to do a deep dive into this, but we will be able to look at how COVID affected cardiovascular disease prevention activities in our clinics. We published our primary findings last year in JAMA Network Open, and this is the link to the primary paper. This is the sample size. Overall, you can see a median age of around 60, and as reflective of our HIV clinics in Cleveland and Durham, about 80% male and 60% Black or African American. Many of these patients were at fairly high CVD risk. Many of them had comorbid cardiovascular disease. But interestingly, the systolic blood pressure was not that high at baseline. So some of these people were relatively well controlled at baseline. These are our primary results. You can see for systolic blood pressure in the repeated measures analysis, we see that we found about a 4.2 millimeter mercury reduction in systolic blood pressure over the course of the 12-month study, and a 16.9 milligram per deciliter reduction in non-HDL cholesterol. These would be expected to result in about 14% reduction in clinical atherosclerotic cardiovascular events for that systolic blood pressure effect, and 9% reduction in clinical events for this amount of reduction in non-HDL cholesterol. We also looked at various tertiary outcomes of the extended treatment cascade, or the hypertension and cholesterol cascades. Perhaps lacked a little bit of power, but we can see certainly a trend towards improved odds of being at treatment goal, particularly for cholesterol. And the particular fractions that drove the outcome of cholesterol, we see that triglycerides was important, as well as LDL cholesterol. And then we did some pre-specified moderation analyses, and the moderation analyses by sex showed that females tended to have more of a intervention effect compared to males. So I'd like to thank the large study team that participated, and definitely the patients who participated in the study, as well as our funders. All right, so I'm going to move on now to talk about what might be different in the African context. We did extra CVD, which was funded in 2018, ran through 2023. The NHLBI decided to put out a call a couple years later, which we responded to, and were awarded another grant to look at improving hypertension care in Uganda. That's called PALESA Uganda, or Strengthening the Blood Pressure Care and Treatment Cascade for Ugandans Living with HIV. And many of the pieces of that application came from extra CVD and were informed by extra CVD. But I didn't mention this at the beginning. There were actually many pieces of extra CVD that were informed by work that we had been doing and others in our team had been doing. Things like task sharing, this idea of using nurses to help extend physicians and improve care and clinical inertia. Using a human-centered design approach to designing interventions. And really key is this concept of remote patient monitoring and using home blood pressure monitoring to improve control. So let's talk about PALESA. So PALESA, again, is part of an NHLBI funded consortium of projects shown here. We're all kind of in our final year and finishing up our clinical trials. So over the next year or two, hopefully you'll see some of these results. This is our team at our meeting in Uganda a couple years ago. These are teams from all over the continent. So PALESA Uganda is a collaboration of multiple institutions shown there that is being conducted in Kampala, the capital city of Uganda, as well as the neighboring Wakiso district, in 16 HIV clinics there. We had the same formula where we began with a mixed methods formative assessment, looking at how the principles of hypertension care were actually happening on the ground in our HIV clinics in Uganda, and looking at different HIV care innovations happening in these clinics, and how might we build on both of those things to develop a strategy to integrate hypertension care into HIV care using a human-centered design approach, just as we did in extra CVD. So this is our design team that we had met over several different meetings, an in-person workshop in particular in October of 2022. So we did a lot of sticky notes, just as we did in extra CVD, and I showed this map, which is called an empathy map, to really understand what are patients and what are providers experiencing in their day-to-day. And for PALESA, we came up with two different strategies, and we wanted to compare these two. So the basic strategy is simply going into HIV clinics and making access to blood pressure medicines free of charge. So kind of removing the problems with medicine access and the kind of the stream of medicines into the clinic, And then also make sure that blood pressure machines were available to measure blood pressure in clinic. That was not happening. And so just by doing those two simple things, how much could we improve blood pressure control? And then secondly, in a more human resource intensive strategy, we decided to um, offer more robust training in hypertension with periodic booster sessions and one-on-one coaching. We offered or tried to encourage clinics to integrate differentiated service delivery models for hypertension care. I'm going to talk more about that in a second. And then we also tried to think how might we do remote patient monitoring in the lower resource context of Uganda, where it might not be feasible to do a home blood pressure monitor for everyone. And then we had a performance improvement program or an audit and feedback approach to providing clinics their performance metrics in terms of the hypertension treatment cascade and seeing how we might improve that going forward. The design of this trial is a cluster randomized trial of 16 clinics, rolled out two at a time in 8 steps. And at each step, one was randomized to basic, one to plus. And you can see the timeline here where we are now almost in the very end of the trial, and all of the clinics have been rolled out in their intervention phase. We also had a fairly unique aspect of the study because this is over 80,000 people living with HIV in these clinics, and we're measuring our primary outcome of documented blood pressure control in all 80,000. We could not conceivably follow all of them for some of the more interesting implementation metrics, so we created what we call a longitudinal cohort or process evaluation cohort, and we are assessing them at baseline, 6 months, and at study end. There are other aspects to the trial that I won't go into detail now, but this is our longitudinal cohort study. So we have a number of patients, people living with HIV, as well as clinic staff who are administered a number of different tools to look at implementation of this strategy. This is our clinics developed through a pilot grant that led to this work. We start with a calcium channel blocker, add an angiotensin receptor blocker, and then a diuretic. And you may wonder why the choice of these medicines. These medicines are available through a program called the Novartis Access Program at a really favorable pricing. We do training. This is the type of training that many of you who work in Africa may have seen before. But in addition to group training, we also offer one-on-one coaching. And then we get together at the same time as the HIV program kind of looks at their HIV metrics and analyze the hypertension performance metrics and feed that back to the clinics. So I mentioned differentiated service delivery for HIV care. This was really important to us. This has really revolutionized HIV care in Africa over the last decade or so. And it's the idea that complex patients need more care, but stable clients can actually be transitioned to care in the community through programs like fast track drug refill, where clients come directly to the pharmacy and just pick up their pharmacy or their medications without having to see a clinician, or having community client-led ART delivery, where one client may come to the clinic, pick up all the meds for all of their colleagues and friends back in their community, and then go back in the community and distribute those, or community-based drug distribution points. And then finally, multi-month refills, making sure that patients don't have to come back every month to get their medicines. So how do we kind of match the hypertension care delivery to the HIV care delivery in a way that works and is patient-centric? So some clinics found that this was easy to do and others much more difficult. This is just one example of a clinic which had most of their patients with hypertension in a facility-based intensive management. That means the patients are always coming to clinic to get their medicines and to see clinicians. And really over the course of many months, they were not really able to transition those clinics out into more community-based models. Whereas this is another clinic that was really able to do that from the beginning. And even if some of the patients had to come in for facility-based management at the beginning, over time they were able to transition them to more community-based models, or at least a model like fast-track drug refill where they would not have to be seen by a clinician every time. We were concerned about whether any of these strategies would lead to increased health worker burnout by asking people to do more. Would that make them more burned out? And in fact, in data we're presenting in Rwanda in July, we see that there's less personal burnout, less work-related burnout, and less client-related burnout in general, with no significant differences between the two groups. We're very, very hopeful that we'll see a significant improvement in our hypertension control rates with this intervention, and pilot data from Martin Mudu shown here with Dr. Glass from Fogarty. Based on his one clinic in Kampala, they achieved really high rates of hypertension control in that clinic, and so we're hopeful to see a similar response rate in our 16 clinics in the districts. So really a lot of acknowledgement needs to be made to the team on the ground in Uganda, including the contact PI of this study, Fred Sematala, and others shown here, as well as their statisticians and others from Yale, and the NHLBI and our funders. So what is the next frontier? So I mentioned this at the beginning, but many of the barriers to care that we see in Africa are the same as what we see in the rural Mountain West. Things like long travel distances. And how do we maybe take lessons learned from our work in Uganda and elsewhere and apply that to improving care in the rural United States? I think this is a really timely topic to be talking about in our current environment. So we were awarded in July of 2023 a Health Equity Research Network grant from the American Heart Association. We are the coordinating center at the University of Washington, but there are 5 projects, including, as you can see, and 3 other projects at Oregon Health Sciences, Duke, and the Palo Alto VA. Rather than me talking about it, I think I'm really happy to have a video, which you'll see in just a second, which will explain their projects. Again, coming back to this concept that reciprocal innovation can be certainly global to local reciprocal innovation, and we have this phrase now that rural health is global health, and we have some materials. If anyone is interested in accessing those, I'm happy to send you our media toolkit. But there are other axes of reciprocal innovation, and some of the projects in our network are looking at urban to rural and academia to practice as well. So if you want to learn more, please visit our website at ruralprocare.org by scanning the QR code, or simply going to ruralprocare.org. And I'm going to let this play now. The Rural ProCare Health Equity Research Network is one of 4 health equity research networks funded by the American Heart Association that are focused on improving cardiovascular health equity and reducing disparities in cardiovascular disease for various conditions like high blood pressure, for special populations like mothers and babies, or in our case, for people in rural areas. Rural ProCare Network consists of a coordinating center at the University of Washington, as well as 5 projects all around the country, each addressing rural health. This is a $20 million award funded by the American Heart Association, started in 2023 and will go for 4 years until 2027. Reciprocal innovation is the idea that there are shared barriers to health all across the world, things like transportation problems, not enough workforce, mistrust in the health system. And so, if someone in some place around the world has figured out a creative solution for overcoming those barriers, it may be possible to translate that from one context to another.
So I'm a cardiologist in Brazil, and my role in the Grow Rural project as a consultant is to bring to the group the experience in adapting a digital health intervention that was created for US urban population to the Brazilian context. Now I'm bringing the lessons learned to this group to adapt this intervention back to rural US. There is some specificities and shared challenges between these populations, like, for example, long travel distances, restricted access to cardiologists, and also a lower digital literacy. And we all need to take this into account when we are designing the intervention so we really reach this population.
So I'm a family physician here at Terry Riley, and we work with underserved communities, including many rural patients. And when we're working with them in terms of their heart failure, they encounter a lot of barriers: transportation, finances, language barriers, access to subspecialty care, and even coming in to see me in the office can be a challenge for them. So it's something we're trying to work through. I think our rural population are uniquely independent and strong. They're used to working through challenges. And so when they have the challenge of heart failure or other health conditions, and they choose to fight it, they do a great job. And they're willing to put in the hard work that's needed to try and improve their health.
I grew up in a rural community in Northern California and also lived on the Cherokee Nation Reservation in Northeast Oklahoma. I'm a citizen of the United States and of the Cherokee Nation, and I've always been interested in how I could contribute to my communities. I decided to become a Grow Rural Project Fellow because this project appealed to me for many reasons. I love the idea of global exchange of ideas. There's so much we can learn from different people, and this project really is facilitating learning from people, governments, and communities in other countries and bringing those good ideas here to the rural Western United States. Community partnerships are important because communities know what they need. Communities are the experts in their own needs and healthcare, and so medical professionals would do well to partner with communities and really listen and respect them and let them lead. Especially in Native communities, there has been a long history of mistrust and harms and multi-generational trauma. So any medical professional that wants to work in a Native community needs to understand that history and approach with respect and a willingness to listen.
The University of Washington serves as the coordinating center for all 5 projects. Our Grow Rural project is centered at the University of Washington with our partners at the University of Idaho and Montana State. The Cincinnati Children's Group is using their work in Uganda to inform an intervention to improve Native American health. They are screening for heart disease using community health workers and AI-guided ultrasound. The project is screening for methamphetamine-associated heart disease among people who use methamphetamine in rural Oregon. The Duke project is trying to figure out how to use drones to deliver defibrillators to out-of-hospital cardiac arrest victims in rural North Carolina and rural Virginia. The Stanford and Palo Alto VA project is using clinical pharmacists to manage heart failure and improve the care of rural veterans living with heart failure across the United States.
So my role on Rural ProCare is working with projects to think about their interventions and innovations. How do we bring those to scale across the state where they're working and hopefully across the country to have the greatest benefit to the most people? Legal epidemiology is the study of law as a factor in public health. And so when we look at identifying a public health problem, and then we look at the law and the role that that might be having on that population health issue, where those come together, that's where legal epidemiology comes in.
The Rural ProCare Network will ultimately have impact by taking all of the evidence that's generated by these projects and bringing it to scale by connecting with state offices of rural health, the National Organization of State Offices of Rural Health, and working with legislatures to bring these evidence-based strategies to scale. And I can guarantee you that there is absolutely something hiding out there in rural America that will one day be used to improve heart disease in Uganda and Brazil. So we in the Rural ProCare Network are really passionate about this concept of reciprocal innovation, and we are convinced it's going to improve cardiovascular health for people all around the world. And so here are some pictures from our most recent semi-annual meeting of the Rural ProCare Network in Bozeman. You can see people from Cincinnati, from all of the projects here. It's an exciting group, and for those who are interested, happy to speak to anyone who wants to learn more. So I'll end by saying, rural health is global health, and really excited to see where this work takes us. Happy to take questions.
Thank you so much. I can't see people. There's no questions in the chat right now. We definitely have a small enough group that we can have people come off of mute and ask questions. I actually can't see people's pictures right now.
Yeah, I do have a question.
Okay.
Catherine,
Yes.
if that's okay. Yeah, Chris, that was an excellent presentation, and thank you very much for sharing these ideas in reciprocal innovation. As you said, it's a very important concept, and especially very applicable these days. Could you describe some of the as you are rolling out this project, the Rural ProCare project, some of the unexpected challenges that you may have encountered, or things that you may not have predicted, and how are you doing to navigate some of those challenges? Thank you.
Yeah, great question. So, there hadn't really been a lot of research on what I would call kind of the receptivity of local communities here in the United States to ideas or innovations that come from somewhere else. And so, in our Grow Rural project, led by the University of Washington, we have conducted some surveys and administered both a quantitative survey and qualitative interviews with people to just say, our primary care practices throughout the Washington, Wyoming, Alaska, Montana, Idaho region willing to consider ideas from other places that might help them improve care. And in fact, we found that there was a fair amount of receptivity. That I think the bias is that people may be closed off in rural communities, that they may be closed off to other people or other ideas, and that's simply not true. Of course, we found that on occasion, but not as much as perhaps some people might think. Clearly health systems are different. So an mHealth app, a smartphone app that helps patients manage their heart failure. And clearly the health system in Brazil is very different than the health system in the US. So making sure that we account for those differences is important. So yeah, lots of challenges, but what I would say is if you have innovators in one context working closely with adopters in another context, where you have them as part of the team, then this sort of innovation flow can work. It doesn't work as well if the original people who came up with the innovation aren't involved, right? And so what I really like about this is that we're kind of flipping the switch on the global health paradigm, right? It always has been that high income countries go to low income countries to kind of fix their problems, right? And now we're asking experts from low and middle income countries to come here to the United States to engage with us about our problems here in our country.
Thank you.
Can I ask a question as well?
Yes, please.
Definitely just kind of naive to some of the terminology, but a lot of what you described is like community engaged, participatory research, but you also talk about the human-centered design specifically. And I'm just trying to understand what I think it's, you presented about them, but what are the specific human factors that you needed to address for these interventions? And like what's the differences between some of these different ideas? I'm kind of mixing all in my head.
You mentioned CBPR, Community Engaged Research, and Lisa Vaughn at the University of Cincinnati is really a key partner of ours in the Rural ProCare Network. She actually leads a whole CBPR course that we offer. So what I would say is that human-centered design approaches is complementary to a community engaged approach to community-based participatory research. And it just adds a little bit more of a focus on empathizing with the end user. So human-centered design is really about creating a product, whereas community-based participatory research is larger than just creating a product. And so if we are trying to create a product, in this case, an implementation strategy, we want to do that in a way that the end users that will be implementing that, like actually it works for them, right? So it's not kind of academics in an ivory tower designing something that doesn't work for people on the ground. So I think the two approaches are complementary. Um, but Lisa has really taught us how to engage community members, how to do so without kind of this narrative of us coming in to fix, but let's listen to you. What do you need? What do you want? So yeah, they're very complementary approaches.
Thank you.
I have a question. Can I ask a question?
Yes,
Please
Jess.
do.
Okay. You mentioned about HIV, over 40 million. So it has been like 30, 40 years now, even more. Why we are not able to get a vaccine, whereas we are able to get vaccine for COVID within a short period of time? Is that because of the nature of the virus or something else?
Yeah, great question. And I am not a virologist. Moises perhaps could answer better than I, but there are challenges of the way that HIV kind of is able to get into immune cells and hide out in the body and evade detection from our immune system that has made a vaccine challenging. But I think there's been progress, and I know Bill Gates, for one, is optimistic that there will be a vaccine in and perhaps, but it definitely has been more challenging than something like COVID.
Yes, it's clear. If you want, we can have a coffee and I can explain you why I don't believe we will have a vaccine.
Okay, yeah,
Because of the fact that it integrates in the host within probably extremely, hours. And so to have a vaccine that prevents that, it's a challenge that the other infectious disease, the other virus, we don't have with the other viruses.
yeah.
But
Thank you.
it's the same. We can have a coffee if you want my view on the failure of HIV vaccines.
Any other questions? We can also end a little early if.
Well, if there are other people that are thinking of their questions, I will just also thank you for introducing me to the term of legal epidemiology. Thought that was very interesting, but makes a lot of sense, important in the field. I was curious when the JD and PH came up about how this was going to fit in. So that was really interesting.
Yeah, maybe I could actually build a little bit on that,
Great.
Catherine. So I think a lot of, and this is relevant to this CTSAs, right? A lot of the translational science that we do, we think of translation from bench to bedside. But there's a lot more translation that needs to happen from bedside to the White House or to Congress. And policy implementation science, I think, is an emerging field that will really help us do that. And I think what we wanted to do with the Rural ProCare Network is to say, how can we connect researchers to policymakers in a way that makes sense? And doing some of that more scientific approach to understanding policy differences across states, that's the legal epidemiology part. So that if we find an intervention, a clinical pharmacist intervention that works really well, for example, well, we can't necessarily scale that to all states in the US because clinical pharmacists have very different scope of practice laws in different states. So maybe we focus on the states where there is more favorable laws for pharmacists. And so, yeah, connecting the policy piece to the research is how we not only bridge the what we call no-do gap, which is the implementation science. How do we get people to do what we know works? But also, how do we bridge the do scale gap, take an implementation strategy that works and scale it to a larger population?
Chris, I think before we end also, I just wanted to thank you again for taking the time. And this was, I've learned a lot, and I think I'm speaking for everyone who was able to join today. And recording will be available at the CCTST website as well. And thanks again for being such a wonderful collaborator and partner for our institutions over here. We really appreciate the work, the pioneering work that you're doing and that has impact locally and globally. And thank you very much. I really appreciate, we all really appreciate the work you do.
Well, and we appreciate the University of Cincinnati and have many, many good partners there. So thanks again for the invitation.
Well, thank you very much. I guess we will give everybody their 5 minutes if there's no other questions, but thank you again so much.
Yeah, I can ask one small question. So
Good.
you mentioned on communicable versus non-communicable diseases in LMCI in the developing world. So what do you think the future is, that we focus more on non-communicable, or communicable disease will remain
Excellent. Yeah.
a challenge?
Excellent question. This term non-communicable disease a little bit more enthusiasm and funding in particular for the control of really a very heterogeneous group of disorders. Like cancer is not the same as cardiovascular disease. And so ultimately, I think it's been somewhat communicable diseases. I think what we'll see in the next 10 years or so, that there'll be a little bit more of nuance to non-communicable disease, that we won't just put it all in one bucket, but we'll really be able to use data from, for example, the Global Burden of Disease study to say what non-communicable diseases do we need to be focusing on? What are the key risk factors that are kind of underlying many non-communicable diseases, such as hypertension or adverse weight gain, for example, and how do we tackle those? I do see a movement away from infectious disease towards non-communicable disease, as we see the global burden of non-communicable disease is quite high. Not that infectious disease research is going away anytime soon. We obviously just got through COVID, but I think that there is a shift. Hopefully that answers your question.
All right. Well, I think that might be it. All right. Well, thank you
Thanks
again
so
so
much.
much.
It's great to be here.